I was just going to say, Laura, I'll let you introduce what you're talking about yourself. I just wanted to say thank you so much again for agreeing to talk and or helping out to talk. It's incredibly appreciated.
Yeah, absolutely, my pleasure. Hi everyone, I'm Lahir. I'm an anaesthetist from Melbourne, just here on sabbatical. And I think I met a few of you already, which is great. Hey, now the first thing I got to tell you guys is my internet connection is really unstable right now. So the first plan is if it's really bad, we'll get everyone to put their cameras off. And then if that doesn't work, I'll try hotspot as well. And if that fails, then that's all I got. And good luck to us. Also, I'll record this whole thing and put it up on my YouTube channel, and I'll send a link to Dave to spread around as well. Now, yeah, so the title of this talk is 3 Advanced Concepts All Consultants Know. I'm just going to close this door. I'll be right back. Okay, yeah. So pretty much, I thought of this because there's a few things that an anesthetic consultant, I assume a lot of other consultants do think about, but we don't really, it's not something that's necessarily taught in med school often. And I thought I'd go through those particular things just so that you have a vision of what advanced training, practice, and communication kind of looks like. Now, so the ground rules, again, I'm going to ask you guys a lot of questions and get a lot of volunteers. I'll move pretty fast through it as well, but you can always watch back on the video to get that experience. I just really don't care if you say a really crappy answer. It's about learning. If you say good answer, fantastic, but the more crappy answers you give, the better we all learn, so that's good. I've got this YouTube channel with lots of information for junior doctors and medical students as well. Yeah, there's a couple of playlists, and there's probably the most useful things for you guys. Good. So I want you to really start thinking with kind of the frameworks that I would think, and I think a lot of my colleagues would think. I want to give you lots of practical examples for kind of real life stuff and make you a gun doctor. Like everything I want to give you here is just really, super practical that I would use on a daily basis. So the first one I want to go through is whether to proceed or postpone with surgery. Just such a common question that, every time you have a patient, medical or surgical, where you're thinking of going for surgery, you're thinking, well, is this patient safe for surgery? Are they fit for surgery? The real way to perform an assessment, or at least communicate that as findings of your assessment, and then the critical issue. Now, I've got 1.5 hours or so. The most important part of this is that first one. I think that's by far the biggest ticket item. And if depending on time, I'll kind of go through the other stuff in a very didactic way, but just to show you the principles, which I think are pretty simple and easy to learn. So let's get started. So, hey, just to get someone's involvement, has anyone had come up with this question of like, is this patient fit for surgery? And you ask your consultant, your surgeon, your anaesthetist, and it just seems like a bit of a puzzle. Has that happened to anyone so far?
I've had one case last year where we had a lady who was from Broome, actually, and this was down in Charlie's, and she needed surgery for her foot for some chronic foot pain issue. So it wasn't a life-saving surgery, but it was certainly causing her a lot of suffering.
Yes. And
she also had comorbid asthma. Okay. And she came all the way down from Broome. And in fact, she wasn't even from Broome. She was from a remote community. And on the day of the surgery, her anaesthetist cancelled the surgery on the basis that they assessed her asthma as being poorly controlled, and there was no recent spirometry results. And they just sort of didn't really know what they were working with, and it was sort of a puzzling situation for us because we thought she seemed pretty well. I was on the surgical side of things, and we had to unfortunately send her back to Broome because there was nowhere for her to essentially stay in Perth while she was getting these results. So it was a huge decision to be made, and I think it was a huge call that the anaesthetist made, and they sort of stuck by their guns and said, this is actually the best decision. So that was probably one of the few examples that I have of seeing that sort of decision being made.
That's really great that you raised that point, because so I'm going to be honest with you. There's such a varying degree of the way anaesthetists perceive risk. So, you could ask 100 anaesthetists whether to go ahead or postpone that case, and you probably get a bit of a spread over it. And obviously not being there, I'm not going to make any comment about that particular anaesthetist decision. But I think that's such a useful thing and experience to have, because I'm hopefully going to give you absolutely the answer to that question. So you can make your own mind up in that situation. And as a junior doctor, then what's most useful about that is that, say an anesthetist does cancel, or decide, they might decide to proceed with surgery, and you're thinking, oh, this is a bit dangerous, or they might want to postpone with an operation we think is, this overall is going to benefit the patient. I'm hopefully going to give you the strategies that you can absolutely make the decision on your own, even as a junior doctor, as an intern, as a medical student, because this framework is very evidence-based. So yeah, I think that's going to be the aim of it, because I know that this was an absolute mystery for me, and this framework just, I was thinking, why didn't someone tell me this when I was a medical student? It was existing knowledge that was just, guidelines that already existed in the world, and no one showed me this. So I was surprised that it took me so long to discover this. So this is something I use day in, day out. I think the Broome context, the rural context, like William said, it's so much more high stakes, like in the city, someone comes in and they get canceled, you can probably rebook the next day or the next week. But a lot of your patients, you have probably spent hours of planning to get that one little operation in that one patient transported with family, without family accommodation, who knows what else. And the cancellation is a massive deal. So there's these kind of socioeconomic and logistical factors that I fortunately don't have to deal with in the big city as much as you guys will. So hopefully this will really address that. Does anyone else want to share an experience before I move on? I'll keep this really informal, like always. Please tell me if you have any questions, or if you want any clarification at all. So like, as a junior doctor, you'll see many patients that need surgery. They'll be unwell and have lots of comorbidities. But how do you know if they're safe for surgery? And that's really what we want to try and get to. So this is the answer. It's an evidence-based structure with an easy way to remember it and enable you to operate at a high level with solid understanding. And that's a big sell, but like I just guarantee you that you can make decisions as good as I can if you follow this framework. So like with everything, if you can refer to a really, really evidence-based clinical practice guideline, this is the one. So this is the 2014 ACC-AHA guideline. So that's the American College of Cardiology, American Heart Association. And this is the body that I'd say most of the world looks at, definitely Australia. So they, if you haven't heard of them before, just look it up. All the guidelines are free. It's not like you've got to subscribe to any, publishing organization. You can easily get them just from a Google search, and they'll cover everything that's cardiovascularly relevant. Atrial fibrillation, heart failure, valve disease, whether to operate or not, pacemakers, everything is on this. I go through this in a very advanced level. So this is going to be kind of the bare bones of it and enough for you to make decisions. But you can look at some of my final exam or part 2 exam playlists. And I've got a lot of these guidelines lectures if this is something you're interested in, especially if you're doing anesthetic surgery or cardiology. I imagine it'd be very relevant. So just remember, there's something I remember one of my mates told me, everyone's got an opinion, my opinion, Dave's opinion, your opinions. And often that opinion is, goes ahead with practice depending on the seniority of the person and their experience and maybe the strength of the argument. But just remember, once you have a guideline, you kind of trump opinion. Opinion is opinion, N equals 1. It's anecdotal. But if you've got expert consensus, it's probably better than your supervisor's experience. I apologize to any consultants here who may be upset by that. So this is the guideline. It's a pretty busy flowchart, but I'm going to make this really simple for you, okay? Every anesthetist loves morning coffee. Now, I love this because I made it up and because it's true. I don't know, a big part of my morning is making sure that I have that coffee and it just makes me happy. So this really speaks to me. Now, what does that mean? E is emergency, A is active cardiac condition, L is low risk, M is METS, and C is will testing change management. And so at each of these points, if you literally follow this flow chart, if it's an emergency operation, you proceed. If it's not, you go down to asking the question, is this an active cardiac condition? And if it is active, you refer. If it's not active, you go down to, is it low risk surgery? If it's low risk surgery, you proceed. If not, you go down, is there formats achievable by this patient? If yes, you proceed. Finally, if there's not formats, but it will testing change management, which it almost invariably does, then you either refer to cardiac testing or proceed with surgery. That's the whole talk in one flowchart. And I think we can go through some of the detail to help you guys make decisions. Hey, so just a quick question. Mark or AJ, just because your camera's on, why do we proceed with emergency surgery regardless of how bad this patient is?
Because they might die if they don't have it.
Yeah, it's really obvious, right? You know, someone's out there bleeding and there's just no time for thorough evaluation. Imagine you optimize in that half an hour or whatever space of time, and you increase your monitoring, and then you crack on in an appropriate place. So that's it. Emergency surgery, that's how that is. And we'll go through a bit of detail and some examples in a second. Now, what's an active cardiac condition? Hey, Corey, what's an active cardiac condition, do you reckon? And if you're not really sure, just have a guess, because I reckon you'll probably guess it right. Sam, what do you reckon?
Well, I suppose it's something that's actively impairing their ability to fuse, or I suppose is a relative. Is an issue to them right now, as opposed to like hypertension, which has been treated, or something else that's been treated and is stable.
Yep. And what kind of lesions do you reckon of the heart would be active as not active?
As in, I'm not sure what you mean.
No, that's right.
Sure.
So if someone had some level of ischemic heart disease, what would make it active versus not active, do you reckon?
Not sure, to be honest. Like, as in the acuity of it, or the.
Absolutely, that's definitely one of the things.
Yeah.
So it's pretty much this arbitrary scale of severity that we've defined. And so when you said the acuity of it, yeah, absolutely. As soon as it's an acute cardiac or new onset, that's active. It's unstable angina, that's active. It also spans a whole bunch of other things. And these are what we've defined it as. So a recent myocardial infarction, so that's, you know, the acuity of it. Unstable or severe, so that's acuity plus severity, according to the Canadian class angina scale. Is it decompensated heart failure, NYHA4, which is worsening on new onset? And if it's valves, is it severe? So, you know, severe aortic stenosis is bad, but moderate aortic stenosis is bad, but it's not an active cardiac condition. Symptomatic mitral stenosis, same. It's bad, it's active, but less than that, it's not. If your arrhythmias are, you know, actual high-grade heart blocks or super fast rhythms, again, that's active. So we pause at that point and go, okay, for elective surgery, we got to get this sorted out. We do not pass go, and we don't go ahead with this. And these are some really, you know, pretty steadfast endpoints to how we make our decision. So let's say it isn't. So let's say the patient has lots of cardiac disease, but none of it's active. And then what do you reckon low risk surgery is? And I might ask Mark's iPhone.
Something that doesn't need to have general anesthesia.
That is a pretty good the fact that you said that is really good, because most of the time you're absolutely right. A lot of your sedation cases are sedation cases because your incision is small. So probably a more robust definition is low risk surgery is anything that just has a very small metabolic requirement to heal. But as a general rule, the fact that you said sedation is actually pretty much spot on for most situations. So well done. So any surgery that's, you know, just scopes, you're not really insulting the body with this massive laparotomy lesion. Cataract surgeries like that, superficial surgeries, you know, like little skin lesions, melanomas, and, you know, SCC removals or breast lumps. Pretty much any surgery that you can just walk away from that day. So ambulatory surgery, day surgery, all of these are low risk surgery. If it is low risk surgery, you just proceed, assuming all the other things. Finally, what is a MET? Hey, not everyone knows this. So can someone volunteer for me what a MET is?
Oh, this is going back a little bit, but I think it's like one metabolic equivalent. And I think it's like the amount of you know, it takes you to burn like 1 kilowatt or something of energy. not kilowatt, 10,000, 10,000. It's
You know-
10,000 something.
you may be right about that, but the definition I've seen doesn't involve kilowatts or anything. But hey, you may be right, so I'm not going to say that's wrong. It's defined by the metabolic work required, or the basal metabolic rate of someone's at rest and comfortable, which may be a certain value. So all of this is really interesting, right? Because there's this Duke Activity Status Index, they call the DASI, which I'll show you. And so a 70 kilo, 40-year-old male sitting quietly uses about 3.5 mils per oxygen per kilo per hour, is about 250 mils per minute. And this is really robust. Like, say you have a patient who's got, a lung full of oxygen, that comes to a couple of liters of oxygen. The time they will take to desaturate is when that oxygen reserve in their lungs is used up. And it's pretty robust. Your body will need 250 mils a minute to just exist. 4 METs is 4 times that. And studies have shown that 4 METs, like this massive study, thousands of patients, shows that those that can do about 4 METs have a better survival perioperatively. So that's often why you'll see someone, anesthetist asking about what's the exercise tolerance. So, as a resident, if there's any piece of information besides all the usual stuff when you maybe refer to anesthetics for a referral, it would be to say blah, 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 age, gender, what the operation they're having in past history, and what's their functional capacity, what is their exercise tolerance, and get down to detail. For example, if they can walk, briskly, or, they can climb up a couple of flights of stairs without stopping, then they can probably have the surgery. Because, that's a very low bar if you think about it. So yeah, this is that benchmark that correlates well with perioperative survival. And the reason I think that is because it's not really the anesthetic that kills you in an operation, because you're monitored really carefully by an anesthetist, and we solve problems very quickly. It's the perioperative and postoperative recovery that really cause the problem. So think about this: if your body cannot raise its metabolic capacity 4 times at rest, that means that, say you're in bed trying to heal from a massive laparotomy wound, your body's going to have to mobilize oxygen and nutrients to that area for inflammation, for treating complications, infections, DVTs, and all the rest of it, and healing that tissue as well. So 4 METs is probably about that range where you're able to sort out all of that stuff, or your body's able to sort that stuff out. That's why we need that 4 metabolic equivalence, where your heart and lungs can coordinate to pump oxygen and nutrients to the relevant areas. 1 MET, if all you can do is sit like a vegetable, that's terrible. If you can do 10 METs, it's absolutely fantastic. That the people who are very fit having an operation, who are marathon runners and whatever else, they will breeze through most operations because the healing time and problems just don't happen the same way. That's the DASI questionnaire. I mean, if you want to go advanced level to try to get a really quantify, this is also available. I think this is the link to my calculator, MedCalc, online. So yeah, really useful kind of way to just find out the exercise tolerance. This will often be the point of difference in this whole flow chart. Often surgery is elective. Often patients don't have active cardiac conditions. Often it's not low risk surgery, but you then need to figure out their metabolic equivalents or their METs. So this is probably a really useful way of doing that. Now, the final one, which is C for coffee, C for change management, is will testing. Like let's say this patient can't do 4 METs, will testing change management? And almost invariably the answer to this question is yes. So you very rarely does the patient go, you know what, no matter what you tell me, I am not going to have a stent put in or some minimally invasive operation, because these days you don't need a full stenotomy and all the trauma that comes with that. You just have a stent and you might be able to crack on with the operation. So if you think that they don't have 4 METs, almost invariably they'll go to cardiac testing or some kind of stress test. So what was the mnemonic? Every anesthetist loves morning coffee. Hey, Holly, what was the mnemonic? I want you guys to be quick on this trigger. AJ, what's the mnemonic?
Every anesthetist loves morning coffee.
Nice one, William. What's the mnemonic?
every anaesthetist loves morning coffee.
Beautiful. Excellent. Okay, so now let's put into real practice with some real life scenarios using that framework. So literally, I don't want you to do anything but this framework. And so the first person I'm going to ask is AJ, 68-year-old with non-STEMI, 2 weeks prior, ongoing unstable angina. They've had a high-speed motor vehicle accident, free fluid in the abdomen. The surgeon wants to proceed to theatre urgent. So they're having a heart attack and they've had free fluid in the abdomen, so probably bleeding out. AJ, what do you do? Postpone or proceed?
Proceed, because it's an emergency operation and they will probably die. If you don't proceed, they are likely to die. Exactly.
And it's emergency, therefore you proceed. And the reason is that this STEMI might be happening because of the blood loss. So by replacing the blood loss and treating the operative problem, you're probably helping the non-STEMI. It's probably not atherosclerosis where your vessels are tight. It's probably they've got pre-existing problems, but if you solve this other problem, they will probably live. It's a bit trickier one. So fractured NOF, I might ask Mark at the end of that. Multiple comorbidities, all the usual NOF stuff. Ischemic heart disease, AF with unknown exercise tolerance, but let's say the AF is well controlled. Currently in pain with signs of fluid overload, mentally alert. Do you postpone or proceed this patient? Mark.
I'd say that you could probably wait a little bit.
Yeah, and why do you want, that's exactly the right answer. Why do you want to wait in this particular circumstance, and how long should you wait for?
I mean, you could probably, because you can optimize things like the fluid overload.
That's exactly right. And so that's exactly the right answer. This is now an example of, it's still in the emergency category in that top part of the flow chart, but it's urgent. So it's not like I need to rush them MVA style. It's, I've got 48 hours to do this. And if they got something reversible quickly, like fluid overload, then we can treat that with a bit of Lasix and a medical review and then proceed within 24 hours. So there's a few things that you could treat quickly, which is rapid AF. Often they come with that, CCF with the fluid overload. Maybe they've got some level of sepsis, antibiotics, fluid resus. Maybe they got a bit of blood loss from that fracture, and you can top them up to above 100 because of the ischemic heart disease. Either way, you can treat some things quickly and you don't need to rush straight ahead, but it's definitely not the elective surgery. So if you needed to do some CAGs to solve some problem, it wouldn't be reasonable in that time frame. Therefore, you don't, there's no need to go for testing. You just need to sort things out immediately. This next one I'm going to ask, let's ask Ni or Nai, 70-year-old male, PR bleeding secondary colon carcinoma, type 2 diabetic, cholesterol, hypertension, unknown exercise tolerance. What do you reckon coming for the flowchart, Nai or Ni?
So I think it depends how hemodynamically stable they are.
Totally stable.
Like,
everything is as you see it there. They just have got a little bleed from a colon carcinoma.
Just a little bleed. Then I think you've got time before you go to theatre, so you could get a referral in.
And what would you want to test here? Yeah, you're thinking of, like in a track where you're thinking there's unknown exercise tolerance, therefore you're worried, right?
Yes.
Beautiful.
Yes, because you don't know how well they'll manage actually going under anesthetics. So will they be able to like have that post-operative healing?
Yeah, good.
Yeah.
So you're not wrong about that. Now, what is the time frame we should generally do colon carcinomas or other cancer operations? Is it elective or is it more urgent than that?
Selective, I think. Yeah. I'm not too sure.
No, that's right. So this whole guideline actually talks about these. So these three examples were like absolutely emergent, urgent within 48 hours, and this one's called time sensitive. And so this would be roughly in the 2-week mark, depending on the cancer and what the surgeon says. It's a tricky decision, okay? So you're not wrong about being worried about exercise tolerance, but generally speaking, there's not, if we do find something with a stress test, about the heart, there's not really much we can do. Like you're not going to do CAGs because the recovery is too long before you do the colon carcinoma. You're not necessarily going to put a stent in because then you'll need to anticoagulate, and that's not possible for a colon carcinoma with a big operation. There's a lot of gray areas here, but generally speaking, again, this is time sensitive. So generally speaking, we have to err on the side of proceeding, but getting everything else, extra monitoring, HDU backup afterwards, and all of that, if this is a real problem and not just defunctional. So just remember, that was all in the emergency category, but just varying degrees of urgent. Again, there's a few more gray areas here. So there's probably a small number of people who would end up having a stress testing. So you're not wrong, but generally speaking, proceed with this. So these are emergency, urgent, or time sensitive. They generally need a nuanced discussion. But yeah, you probably want to proceed in some time frame that's reasonable. Okay, I might ask, let's go with Ali Hallstrom. So 60-year-old lady, lap collie, chronic AF, now with rate of 140, no symptoms. When would you proceed or postpone? Go, Ali.
Hello.
Hey.
For this lady, I would probably proceed.
And actually, I want you to go through the first thing. Is it elective or emergency? Let's say it's an elective, like it's just a lap collie.
Oh, okay. If it's elective, so it's not an emergency.
Yeah.
Does she?
Is it what's the
Does
next
not
one?
have an, no, I'd say it's not an active cardiac condition. If it's, well, it's sort of on the edge, because if it's chronic and long term and it's been stable, but she's still got like borderline high.
You're thinking of the right way. It's chronic AF, but now it's acute because it's a rate of 140. Like that in anyone's mind will be called an active cardiac condition. And these ones can be really horrendously unstable under anesthesia. The times I've had to go ahead with a rapid AF for urgent procedure, it's just crazy how unstable they are. So yeah.
So given that it's not a low risk surgery, that she probably does need a referral for cardiology review and try and get her AF under control first.
Exactly. We don't proceed. We postpone, and the referral might just be, hey, cardiology, what do we do? And we give beta blockers and amiodarone and sort it out. We don't even have to worry about the next thing, which is, is it low risk surgery? Because we're just going that flow chart. And from active, we go to proceed.
Okay.
Yep. So active cardiac condition, refer. Don't need to look at anything else. I might ask, next person up there. Let's go with Hannah, 60-year-old female, laparotomy for incisional hernia repair. Patient has rheumatoid arthritis. You notice a systolic murmur. Going through the flow chart, tell me your thoughts. Hannah.
Well, it's not an emergency.
Great.
And depending, I think the systolic murmur is an active cardiac condition that needs investigating.
Fantastic. What systolic murmurs mean? Well, like what pathology has a systolic murmur that's active, makes an active cardiac condition?
Like aortic stenosis or
fantastic. Yeah, exactly. And which one of those is bad?
I don't know, I'd say both, but aortic stenosis is not good in the anesthetic context.
I'm glad you picked that, because mitral regurg under anesthetic context, even at severe levels, it's really well tolerated. So I barely blink at mitral regurgitation, even if it's severe. Aortic stenosis, when it's severe, that's like, okay, here we could have a real problem with this patient. So yeah, your gut feeling is absolutely right. You're also right that this could be a severe lesion. Therefore, if you know how to work an echo probe and figure out whether it's severe or not, great. Otherwise, you probably want to go for testing with this to be conservative. Again, there's a few gray areas. If this patient has really great exercise tolerance and just no signs of severity, you may proceed as well. But at a junior level, you want to err on the side of postponing this one. It's elective. There is probably there could be an active cardiac condition. So you'd err on the side of referral unless you had better evidence. Might go for Sam from Mark, Sam and Hannah's room. 50-year-old male, inguinal hernia repair with trifascicular block with multiple fainting episodes. Following the flow chart, what are your thoughts, Sam?
So again, that would be a non-emergency surgery.
Yep.
Multiple fainting episodes, I would put that in the cardiac active case. So I'd say I'd be.
Beautiful, and that's really good. So I've made this kind of active, and just to give you a bit of context, I see probably a patient with trifascicular block once every couple of years, but doesn't have symptoms. And each time I call the cardiologist, they always say, yeah, it's fine, it doesn't progress. Trifascicular block with fainting episodes, that's probably something a bit weird happening, like maybe they just kind of keep going into complete heart block then out. So this is definitely, you're right, active. Often though, the context of trifascicular block is they're all pretty stable. Beautiful. So again, these are all active cardiac conditions. They have high mortality, you postpone, and you refer. Next one, I might ask Mark from the same room. 78-year-old female, recent echo showing moderate aortic stenosis for cataract surgery. Unable to walk up a flight of stairs due to arthritis. Yeah, Mark, using the flowchart, what do you reckon you do here?
Well, it's not emergency surgery. I'd say it is an active, yeah, it was AS was active.
Oh, so I didn't emphasize that. Severe AS is active, and less than severe generally is not.
Oh, that's right. So then, maybe not active, but unable to walk up a flight of stairs. Oh, it's due to arthritis though.
That's right. So do use a flowchart. It's not an active cardiac condition. What's the next letter and word?
Is it low risk?
Beautiful. What's the surgery?
It is cataract surgery. So I imagine low risk.
Great. What do you do? Postpone and proceed.
Proceed.
Exactly. So it's interesting, right? This patient, I do hundreds of these cases a year. Everyone looks terrible. They're 70, 89-year-old patients coming in for, this cataract operation. Often they have the worst heart disease and everything else going on. They can barely sit still and lie flat. But because it's a low-risk surgery, you can proceed very safely. And there's countless series of studies showing that this is a very safe operation in even the worst patients, as long as they're not actively having an issue. So yeah, elective surgery, no active conditions, low risk. Hell yeah, proceed. And please tell me if you want any of this clarified, because I'm not sure how much experience people have had in the perioperative situation, and I don't want to be too flippant about just saying, yeah, hell yeah, just go ahead with these cases. Don't you worry. But that's what the evidence shows, and that would be my practice. 60-year-old male with lap collie, walks 1 kilometer every day, no past history. William, what do you reckon? Go through the flow chart.
Not an emergency. It's a lap collie, I assume, as long as he's not sort of, septic or any other indication for surgery emergently. He doesn't appear to have, based on the information I have, doesn't appear to have any active cardiac conditions. I wouldn't say that it's a low risk surgery. And he can walk 1 kilometer every day, which I have to get up the DASI score, but I think that's pretty good.
That is good, yeah. I mean, it depends on a few things, but let's say you can assume that that's 4 mats, greater than 4 mats.
So in that case, you can proceed at that stage.
Absolutely. Now, you've done exactly the right thing, and most people would say this is not low-risk surgery. Maybe with like improved techniques, faster surgery, and the fact that it's ambulatory in some places, sometimes it might be low risk, but that doesn't matter. You followed the right format, and almost every day in and out, this patient, you just crack on in that situation. Okay, next person, Emily Fernandez, 60-year-old male, total hip replacement, AF 70, cholesterol and hypertension, obese, stays in bed most days, walks to lounge to watch TV. How do you process this? What do you do? Postpone and proceed.
Okay, so this is a total hip replacement. I'm assuming this is not an emergency surgery.
Yep.
Active cardiac condition. So does that mean he's got AF and with a heart rate of 70?
Yeah.
Yeah.
Exactly.
Okay. So he's got AF, but it sounds like that's stable and it's not rapid. I don't really have any information about how well that's controlled or how the management of that's been like in the past. or any other medications he's on for cholesterol hypertension.
They're on the meds and it's all stable?
Okay, so it doesn't sound like he's got an active cardiac condition. This total hip replacement, I wouldn't say is low risk. It's quite invasive. Requires a lot of healing time. So let's say it's a high risk surgery, and then he looks like he has really poor exercise tolerance. Although I'd have to do a DASI score, but just from that does not sound great. Given it sounds like it's elective, this is a patient that I reckon could use some optimization, particularly with like that long healing time and, you know, needing rehab and that sort of thing, you know, to implement lifestyle measures and weight loss and improving exercise tolerance before he has surgery.
Let's say because he's got the hip arthritis, he just can't do exercise. He'll probably realistically stay obese. You're not wrong. Prehab is a great thing if you can get the patient to do it and they're motivated and all that. Let's say, in spite of what you do, turns up again, exactly the same level of BMI 35, stays in bed most days because of the pain. What do you do?
Cardiac testing to see how well he tolerates stress.
Yeah, and look, you're not wrong about that, right? So the meds are unknown. So let's say you did do a DASI and the meds are good, as you probably would have told me, proceeding is reasonable. If the meds are poor or unknown, practically speaking, you're not wrong that technically you have an unknown and you can find out that unknown exactly what you said, which is do cardiac testing. You might do a dobutamine or some kind of chemical stress test rather than a physical running on a treadmill type thing. But what happens is a lot of the time, practically speaking, we look at this patient and we go, oh, look, they've got no other risk factors for heart disease, or they do have lots of risk factors. And maybe that's what sways us to going one way or the other. So yeah, you're not wrong about saying to go for testing. A lot of us will say that this is lower risk for cardiac disease and then go down the, this is probably just due to the arthritis. To give you a bit of insight, but this is kind of the gray area that some people will play in. I've just said I would proceed there, but really it just depends on that situation. Let's take this patient. Might ask AJ's iPhone, 65-year-old female, total knee replacement, ischemic heart disease, diabetes, heart failure, NYHA2. They've had a TIA in the past, hypertension, cholesterol, and asthma. Poor exercise tolerance and need help with most ADLs. Yeah, how do you do this?
So it's not an emergency operation. Her heart failure, I guess she's type 2, so she's symptomatic with it, but it's on the more mild end.
Most people would say like 3 and 4 is the severe stuff. So yeah, this is all controlled and not severe. Yeah.
And I'm assuming everything else is well controlled, like her hypertension and cholesterol and asthma. I guess, so it's not a low risk surgery. It's a pretty intensive surgery. She's got poor exercise tolerance, which probably needs investigating a bit further if that's the heart failure, or is that her arthritis with her knees. But if she needs help with most of her ADLs, it sounds like she's pretty poorly. And then I guess, so would investigations change management? I guess they would. So we would do perhaps some like COPD testing, like lung function tests maybe, and maybe cardiac stress testing.
Yeah, absolutely. So you've said everything correctly. You know, you follow down this flow chart of like, it's elective, or not urgent, not emergency, no active cardiac conditions, because I haven't mentioned any there, like everything is stable and low risk. It's not low risk surgery. By the way, total knee replacements and total hip replacements are classified under the ACCHA as intermediate risk or moderate risk operations, so they're not high risk by that definition. And that will be borne out in the studies of these patients generally having total knees and total hips have a mortality of, you know, less than 5% by a long way. this patient, unlike the other one, has multiple cardiac risk factors. So unless they've already been well tested, like say you get these patients in the eastern suburbs of Melbourne, they're well investigated by their cardiologist. Whereas in other places, you might be flying blind. If you don't have those tests, this would be one where most people would definitely go, yeah, let's get some testing to see if this patient doesn't have a really tight coronary arteries based on all those risk factors. Okay. And to recap, the mnemonic is every anaesthetist loves morning coffee. And that's what it is. Now, does anyone have any questions about this before we move on? Like, this is literally what I'll think of day in, day out as I'm assessing patients. And most of the time, yep, you proceed. But every now and again, you know, once a few days, once a week, once a month, you get someone who's really tricky, who's got something going on. And that's where, you know, I really need to think about this as a good evidence-based way of knowing whether to, you know, proceed or postpone, which is what's right for the patient.
So I joined a little bit late, so I might have missed something, but so you're only focusing on cardiac stuff, like you don't care so much about like lung function or other things? That's a fantastic question, because we're about to come to that now. So this guideline is very specifically American College of Cardiology, American Heart Association. So the levels of evidence are very much based on and targeted at cardiac risk factors. It's really great that you raised that point, because a lot of the evidence here actually talks about kind of a broader patient population with multiple diseases. So, okay, are you ready to have your mind blown? So let's say you get a patient with an elective inguinal hernia. They were actively wheezing for the last week. That now is, so let's talk broadly, that it doesn't matter what the condition is. If it's active, by definition, it's unstable. And if it's an organ that could cause a lot of problems for you, like your lungs, your kidneys, your liver, whatever it is, you really do need to postpone. So this, I translate that guideline, not just for cardiac stuff, but for all stuff. So this is, you know, it's an elective operation. It's an active lung process. Therefore, I postpone. Often that time frame is pretty short. Like, say, most of the patients who have wheezing that I find coming to me for elective operations, they've got bad lung disease. They're a smoker. They've got wheezing. And what I do is I give them salbutamol, nebs, and Atrovent, or these days through a spacer, until that wheezing stops or is very mild, and then I proceed. Or I do a non-general anesthetic technique, like a regional block or something. Just say it's a peripheral operation, hands, arms, legs, feet. I can just block that limb, and I don't have to put a tube down their throat, which is really high risk for severe bronchospasm. So let's now imagine that patient comes back and they've got well-controlled moderate to severe asthma, but it's for a lipoma excision. So again, same framework, it's elective surgery, but now they've got no active condition. It's a low-risk operation, therefore I proceed. I can do this with just a bit of local anesthetic. 30-year-old elective open lap chole, they've got known COPD, they've had multiple exacerbations recently. Again, what do? It's an active condition, so it's elective operation, active condition, therefore I postpone and treat. Then they come back weeks later. Now they've got well-controlled COPD with good exercise tolerance. It's elective surgery. There's no active conditions. It's not low risk. They've got greater than 4 METs based on this. Therefore, I proceed. So that really is where I try to transition a lot of the evidence from a cardiac guideline to make decisions for any patient. So, just to modify that, it's emergency surgery. Doesn't matter what the active organ disease is, I proceed. If it's an active condition, this could be a recent ERTI, acute asthma, exacerbation of COPD, acute renal failure, acute liver dysfunction, whatever it is. If that organ is, vital, like let's say it's an active, active small skin infection. If you're doing another procedure that's got no relevance to this, then, of course I'm going to proceed, like, a lap chole with a bit of a skin infection, proceed. However, if it was a cataract or a metal being implanted and they got active cellulitis, I would consider that active and then I'd postpone. Low risk surgery in studies of lots of patients, not just cardiac patients, means that they're very low risk of having problems overall, so I proceed. And 4 METs again was in a very broad population group. And then will testing change management? Again, often the answer is yes.
And there's many ways you can test all the other organs, spirometry, cardiopulmonary exercise testing in some centers, as well as, whatever the organ is, you can test it. Any questions about that? And AJ, did that answer your question? Okay, so really that summary is, I just want to give you an evidence-based approach to the cardiac patient, know when to proceed or postpone, and have an approach to any disease state for surgery. And yep, the mnemonic that I use every day, every anesthetist loves morning coffee. Hey, so the next couple of things, a lot of this might be pretty obvious as well, but I'm hoping that you'll take something away from this because again, I think it's really important to the way I think about cases these days. Hey, so when you try to assess any stable patient, what's your approach, Ali?
Hello. If they're stable, I guess I probably go for a systems review rather than the A to E of acute shit.
And your systems review, I assume, is like a history examination investigation. But yeah, exactly. Stable patient is history examination investigation, and then an unstable patient is doctor's ABCD. So, whether you're assessing a patient's pain or chest pain in ED, or it's a 5-year-old's level of dehydration, it's always history examination investigation, unless they're unwell, in which case it's doctor's ABCDE. So this whole thing is, kind of what your bosses will probably want to hear most of the time. Now, the point of this is to make a diagnosis. And obviously, that's very obvious, especially when you're in ED or a GP setting. You want to ask a whole bunch of questions to assess, and then you make a diagnosis, and then you treat. Now, so with the diagnosis, we can then commence treatment, and you can have conservative or invasive treatment. I'm going to go through this quickly because this is probably very kind of basic stuff. So, if you've got someone coming to you with occasional chest pain, you ask a whole bunch of, systems review questions aside from the normal kind of history stuff. So history presenting complaint, and you do all the pain questions and situational questions for chest pain. You do a whole systems review, and then you ask all the past history, family history, and all that kind of stuff. Really, tedious, some might say boring stuff. Now, I don't have to go through this. This is kind of at a lower level. But essentially, each of the questions means something, and therefore, you take from it certain things that you can then do, dictate your management. But now, what I want to go through is like, how do you get to the next level expertise and understanding? So, hey, this is a bit of a loaded question, William. What do you reckon? So, after diagnosis, so you're taking a full assessment of the patient, and let's say you find all of this information out. Besides diagnostics, what is the next thing that you think is most important about synthesizing on this patient? I'm so sorry, but this is kind of like a mind reading question, but have a go anyway.
I think you sort of dropped out there a little bit. Was that in relation to okay, this is the information I've got in front of me. Okay.
Yeah. So let's say you've taken a good assessment and you found all of this information. I initially said the whole purpose of a history is to make a diagnosis, which is absolutely true. And what's the next thing? Like, what do you want to synthesize from your findings to when you're presenting to your boss?
Okay. My first thought was severity.
Brilliant. Well, now why does that matter?
Oh, well, if it wasn't too severe, there may not be too much to optimize prior to the operation, or at least you might not be as worried about postponing the operation to have a period of optimization.
That's really great. And so, William, the fact that you said severity, I'm really glad, because that's kind of the whole point. Like, whenever you see say you look at any organization or specialist group, whenever they look at a disease, there's always some eponymous name or some kind of scoring system. And each time the scoring system really rates on a scale of 4 or mild, moderate, severe. Severe stuff often needs treatment and optimization, like you mentioned, and the mild and moderate stuff needs it less so. Like, it's just less disastrous and hazardous to the patient. So severity is definitely one of those things. Now, there's one more thing. severity and one more thing. If you were to guess what else you want to figure out by the history, what would that be?
Acuity, maybe.
Fantastic. And I use severity and stability, but that's pretty much acuity. So yeah, so let's say I get all of the information. The most important thing after this is severity and stability of disease. So you did really well there. And so I ask, everything I ask after I've got these symptoms is the severity of the symptoms. So, a medical student history, you get out, you can ask the questions from Tally O'Connor, but then the next level is you get, categorical amounts of what someone can do or how often they have the problem. What's the onset and offset of it? Was it new? Was it old? Was it stable? Was it unstable? You really want to get to presenting severity and stability, because that tells us what we need to do, whether we can just hold off or whether things need to be done urgently. And so that's why, all your scoring systems, your gradings and your echocardiograph gradings, they're all based on judging severity. So I think this is really, really important that, when you're presenting, you know the diagnosis and you make an assessment of severity, so that you're not just repeating the history that you've already taken. Like, you get to your exams and you start asking your history and the examiner's right there. And when you present the history, you just regurgitate history, examination, investigation. It doesn't really show that you're synthesizing the information. It's kind of like, well, you're just repeating what the patient said. You're not really processing it into a new thing. And so that's why I think it's really important to know this. And then once you've made your assessment of severity, whether there's a scoring system or not, you can make a judgment of what you think it is, mild, moderate, severe, and then you kind of give evidence to that fact. So yeah, let's say you've got the 60-year-old male patient, COPD, New York fever. What do you do to assess them? Obviously, it's history, examination, and investigation. And then you go through all of that. This is kind of the same point, so I won't kind of, keep going on with this. But let's say they've got this presentation. That's kind of showing that this patient is unstable, like it's a new onset acute disease, and it seems like it's pretty severe. So diagnosis, infective exacerbation of chronic COPD. You present the severity, that's moderate severe, hospitalizations, regular ventilating use, prednisolone, no specialist input, and it's acute, so it's by definition unstable. This means everything when I'm managing it, especially in the perioperative context. So the next thing I want to add is, so you've got the diagnosis, and often that comes to you in the anesthetic context. You determined your severity and stability, and then, William, because you're doing so well, after you've kind of figured out everything you need to know about that actual disease process, if you were to kind of play a bit of Sherlock Holmes and try to figure out other stuff related to it, what questions would you be asking? What are you trying to figure out after that?
Now you've stumped me. My other thought was just like amenability to change. Like, are you going to be able to change this or not? Essentially.
Okay. Yeah.
But I don't know if that's what you're looking for.
No, that's right. Good. Again, this was another read my mind question. This is something I didn't really appreciate until doing my final exams in anesthetics, that we take this history, and the way I take an advanced level history is I think of the disease and I think of the thing that caused that disease, so the etiology, and I think of the complications to that disease. So every time I look at this, I look at cause and risk factors. So that's really, in your medical student learned history, your risk factors, but I'm mentioning that the cause is a really big problem, because whatever caused the ischemic heart disease or the heart failure really matters. What caused the AF really matters. So just because someone comes to you with AF, you don't think about the cause, because you might be able to treat it really quickly. Every disease has a set of complications, and therefore, as soon as I see ischemic heart disease or heart failure, maybe I'm thinking, have they had a valve rupture? Have they had a dilated heart causing fluid overload and lung problems? And maybe they've got renal failure associated with that as well. So if we look at the COPD patient, think about and this is where you get some real wins. If you think of COPD as just COPD and you assume it's smoking history, you might completely miss the fact that it was alpha-1 antitrypsin and their pancreas is stuffed up as well. Or maybe it's occupational exposure and they've actually got a cancer that's brewing, as well. And then what does it cause? It causes repeat infections. So everything that this one disease is going to cause, bronchiectasis, repeated pneumonias, lung cancers, maybe the treatments had their own complications. This prednisolone just causes everything bad. And maybe you've got all of these social issues and loss of function as well. So, really in summary, if I use history examination investigation to find a diagnosis, but then I really try to color that history and present it in a real, I guess a more advanced way by thinking of severity, stability, cause, and complications. And I find that this is just a really clinically relevant way to show you understand the issues. Any questions about that before we move on? So the final thing I'm going to chat about is the critical issue and presenting a case, and kind of how to focus on the most important elements of a case. So again, this is something that we do time and time again in our specialty exams. So I think it's pretty common to a lot of specialty exams where you're not really asked about the basic stuff anymore. So you'll manage thousands of patients. You'll notice a lot of patterns in that time of your training, and that things fall into the normal pattern and are relatively easy to manage. But when you find something distinct about a scenario, I'd argue that that's probably the most important thing to pay attention to. Now, the critical issue could be anything. So it could be, it could be the patient, it could be the pathology itself, it could be your staff, it could be the surgeon, anaesthetist, or the physician, it could be the hospital or the facility. Now, what I mean by that is, say you get a patient who's just having a very normal total knee replacement, but they've actually got a pheochromocytoma. So suddenly the patient is just a normal patient having an elective operation, and they've got this one really big problem. And I'd argue that you have to focus most of your attention and your referral and presentation on that aspect. Maybe the pathology is something really unusual. Maybe, you're doing a lap chole, or let's take the total knee replacement example, but the knee is an osteoporotic knee or hip. Maybe they've also got a fracture inbuilt there that's going to make it more difficult. So suddenly the pathology is not a normal knee replacement, which means that the whole process of recovery and operation is going to be different. In reality as well, like when you're outside of the kind of exam kind of setting, your staff make a big difference. Like let's say you're in a place where you've got just really junior staff in ED. Suddenly it is much more difficult to run that resus with junior staff, and you've got to pay much more attention to what's happening. Maybe your surgeon or anesthetist just takes a long time with the operation, and in the anesthetic context, the surgeon takes a long time. Suddenly, I've got to put I've got to put a tube down. I might put an art line in, and think about all this other stuff that I wouldn't have to with a quick surgeon. And especially in the Broome context and Derby and Fitzroy Crossing and stuff, the hospital itself, like a lot of us in the city trained in big quaternary centers where really we had everything at our disposal. But now, when you're out remote, you've really got to think of the situation and your resources and the distance that you might need to transfer someone. So let's look at a few cases just to kind of explain this point. 24-year-old with right iliac fossa pain started centrally and is now focused at the right iliac fossa, nausea, anorexia. Emily, what do you reckon this is?
Well, sounds to me like appendicitis, that sort of generalized becoming localized sort of pain.
Absolutely.
Yeah,
So it's 24-year-old, so very urgent surgery. And in more detail, you might give, the whole history, which we're not going to go through now. And so my framework for, presenting each of these cases is, like you all know, age, gender, likely diagnosis, urgency, stability, and the treatment. And then I always think about the critical issue. In that case, there aren't really any critical issues because it's just a normal process. But Emily, if I was to ask you then, how about, let's say we take this case, 84-year-old patient, is that normal? And what do you think is going on with a patient that's 84 having right iliac fossa pain in that similar presentation, but their age is 84?
It'd be abnormal in that age bracket, and so you'd want to start to think about, is it something else that's causing the pain, like a cancer, or an obstruction or something like that, rather than appendicitis, which would be more typical in younger patients.
That's exactly right. So, and I definitely, when I went through my training, this wasn't emphasized enough. The deviation from normal is the critical issue, and that's the thing you have to emphasize. So when you present this case, 84-year-old male, right, like foster pain for urgent surgery, and then you go straight in with the age isn't typical appendicitis, and then you're worried about those sinister pathologies, cancer, obstructions, and things that you talked about there, Emily. So I'd argue that when you're in your cases and you know what normal is, then you focus on that problem, because that's what's going to be most important for this patient that's outside of normal. So yeah, age, gender, likely diagnosis, urgency or stability of the case, treatment and critical issues. And in more detail, then you can go through all the kind of usual stuff that your boss, your surgeon, your physician would expect of you. So 60-year-old male presents with tight central chest pain, past history, hypertension, cholesterol, smoker, diabetes. So you've taken your history and you've got all of this. I might ask Ni or Nai, how would you present this case, just using, that summary format? Ni's and AJ?
Something like 60-year-old male presents with typical sounding chest pain with significant risk factors for AMI.
Yeah, that's fantastic. Really brief, gets to the point right straight away. How about if you have this patient? Oh, sorry, this is how I'd say, which is very similar. 60-year-old male, multiple cardiac risk factors, likely acute coronary syndrome, needing urgent treatment. Any more detail, you can, present your full history. So AJ, how about, let's say you're now in Derby. How does this change your presentation? Yeah, if you were to say your presentation again, what do you reckon you'd say? I've said that Williamstown, because that's where I was. That's the example I had from Melbourne.
So am I talking to a cardiologist like somewhere else? Is that what? Or?
Yeah, let's say presenting to you, yeah, a cardiologist or your supervisor in emergency, or yeah, let's say cardiologist.
Well, I guess you'd have to say, like, in Derby, there's no cath lab. Like, it's an RFDS flight of multiple hours to Perth, which would be the nearest cath lab.
Absolutely, and that's kind of the thing you have to emphasize, right? So now the critical issue is actually the lack of interventional services and that urgent need for transfer. So you really have this, potentially disastrous situation just because of timing and transfer. And so, Ali, what happens if the patient had recent cardiac stents?
I'm not sure, they're already sort of in the high risk category, but I guess it determines whether the local treatment versus the delay and definitive treatment is going to be more appropriate for them. Yeah,
so imagine that first patient who just presents with, kind of this new onset acute coronary syndrome. That's bad enough. Once they've had a stent, it just becomes super high risk, because now you've got that whole risk of in-stent thrombosis, which is just notoriously hard to treat. And the normal presentation has changed, and that critical issue needs to be managed immediately. Interventional cardiology, transfer, heparin infusions, antiplatelets, and I'd say the mortality is higher. Depending. So there's a situation that often happens for us in theatre. Let's say you have a 50-year-old female for a total thyroidectomy, and you're doing an assessment in your pre-admission clinic. So let's say you do your normal preoperative surgical assessment, which is a whole bunch of the history-taking stuff. Hannah, what do you reckon? Like, what's most important about the history for this particular pathology?
I suppose you want to know if there's any airway compromise with the goiter, or if there's any vascular or swallow problems.
Absolutely right. So that mass will impinge on structures, and those structures could be airway structures or cardiovascular structures. So you're absolutely right. Pressure effect on those things really bad. Anything else that you want to know very briefly?
I guess also you would want to know their thyroid.
Was that thyroid function?
Yeah.
Yeah.
Like, if they're thyrotoxic, it's probably not optimal for surgery.
Absolutely. So again, when I'm looking at this case in clinic, everything else is kind of normal, like you ask your history, allergies, family history, past history, all the rest of it. But really, a lot of my time is on the most high risk aspect of this surgery, which is, are they euthyroid? Because if they're not, we have to fix that. Retrosternal extension and mass effect, which compromises everything and can work really badly. And I didn't, I gave you a large goiter, but the patient would come in with a diagnosis, and I really need to make sure that this is a, usually multinodular goiter, which is far easier to treat than malignancy, which destroys the structures around there and makes everything far higher risk. So look, that was just a little taste of a few things that I think weren't obvious to me when I was going through my junior doctor training. And I think they've just been really helpful for me as I've gone into specialist training, because it's often what I want to hear, but also what my bosses wanted to hear in real life and in the exams. Any questions about that before we close up for today? So really, what I wanted to go through is just a way of just presenting stuff, but really focusing on what you perceive as a critical issue to give, you've got the snapshot of the whole scenario, but the critical issue is what really needs most of your attention and effort. And then, we went through the assessment, the fact that it's, doing a whole assessment, but then synthesizing that information to figure out what the severity and stability is after the diagnosis, and then being a bit of a Sherlock Holmes about trying to figure out what caused that and what are the complications you'd expect, and trying to rule out in any disease process. And finally, whenever to postpone and proceed with an evidence-based format. And otherwise, thank you very much for having me, guys.
Thanks so much.
Thank you. Thank you.
Thanks, Lara, for everything.
Thanks very much.
Thank you very much.